Tonsillectomy simply is the surgical removal of the tonsils commonly performed on children due to repeated infection. It's typically done as a same-day surgery. The goals of the tonsillectomy episode are to reduce multiple pre-op visits, drive appropriate post-surgery observation periods, reduce inappropriate sleep studies, antibiotic and pathology usage, reduce readmissions, and create a model for ENTs to share practices and design even more effective care. The patient journey for the tonsillectomy adenoidectomy it begins pre-procedure up to 90 days before the procedure to 30 days post-procedure. In the time before the procedure is actually performed, a patient would present to an ENT. Then the pre-procedure workout would be done in a hospital or an outpatient setting. The actual surgery, the tonsillectomy or adenoidectomy, would be performed. The patient would then go to a same-day recovery unit and to follow-up care, or from the same-day recovery unit to the operating room, inpatient recovery, and post-procedure admission, or to an inpatient care and recovery unit with appropriate follow-up care. The number of tonsillectomies and adenoidectomies done in Arkansas for Medicaid, and the source of this data is calendar year 2010. The number of procedures total was 3,498. For Blue Cross Blue Shield, the total number of procedures was 1,311. The performing providers on the Medicaid side were 61 and 74 for Blue Cross Blue Shield. You can also see the breakdown between tonsil surgery, the adenoid surgery, or both. In the episode, the way we've defined it, the episode is triggered by the tonsillectomy or adenoidectomy procedures, including any outpatient procedures, whether they presented through the emergency department or whether they were inpatient tonsillectomies. Those are actually excluded from the episode. A primary and secondary diagnosis indicating conditions that require the surgery are the things that, again, trigger the episode. The time frame, related services, including sleep studies, head and neck x-rays, laryngoscopy, within 90 days prior to the procedure and after, and including the initial consult with the performing provider, related services within 30 days after the procedure, and post-procedure admissions within 30 days after the procedure. As with, as with all episodes, there are patient or episode exclusions for tonsillectomy also. A patient with select comorbid conditions such as Down syndrome, cancer, asthma, cerebral palsy, muscular dystrophy, and myopathies would be excluded. Again, a patient with a UPP on a date of procedure would also be excluded. Patients with a BMI greater than 50 are excluded, and that information is gathered through the provider portal. Patients younger than 3 or older than 21 are excluded. If they are dually enrolled in Medicare and Medicaid, if they are not continuously enrolled for 12 months or during the episode, if they die in the hospital during the episode, or if they left against medical advice. The episodes are also adjusted for certain risk factors. The cost is adjusted based on risk factors such as COPD or asthma, and the episode type, whether it's the adenoidectomy, whether it is the tonsil and adenoidectomy. And only providers with at least 5 episodes per year are eligible for gain share or risk sharing. The quality metrics that we look at for the tonsillectomy episode include the percent of episodes with administration of intraoperative steroids, and then there are a number of metrics that are for reporting or tracking purposes only: the postoperative primary bleed rate, the postoperative secondary bleed rate, and the rate of antibiotic prescriptions post-surgery. For Medicaid, the principal accountable provider will be the primary provider performing the surgery. Other payers independently determine the PAP by considering the following factors: the provider who had decision-making responsibility, the provider that had influence over the other providers, and the portion of episode cost. So let me go over with you the design rationale for the tonsillectomy episode. The episode, again, following the bar at the top of this particular slide, the episode begins sometime 90 days pre-procedure. The actual surgery procedure is the trigger, and then the episode ends 30 days post-procedure. The episode includes the following services: preparatory visits, labs, imaging and diagnostic tests, professional claims for a procedure, inpatient or outpatient facility care. Medication and the 30-day post-procedure admission are also included. In terms of the design rationale, the trigger identification, we're only looking at outpatient tonsillectomies and adenoidectomies as potential triggers. So the episode then is triggered by that procedure and appropriate primary or secondary diagnoses. The pre-procedure window begins the day of the first PAP visit within a 90-day window prior to the procedure. Any ER, inpatient cost and pre-procedure window will be excluded. Any medication in the pre-procedure window will be excluded. The post-procedure window covers all related services within 30 days after the procedure. Inpatient post-procedure admissions within 30 days as defined by the Bundled Payment for Care Improvement Initiative. Patient exclusions. Select comorbid conditions within 365 days prior to the procedure or during the episode. Some patients with certain comorbidities may unfairly increase a PAP's average cost due to their inherent medical conditions. Therefore, they are excluded. Pregnant during the episode. Tonsillectomies and adenoidectomies performed on women who are known to be pregnant during an episode window will be excluded due to their potentially complex condition. Again, patients under 3 and older than 21 tend to have more complicated procedures, and therefore they are excluded. Dual enrollment in Medicare and Medicaid. Those persons are excluded in order to reduce the possibility that the costs within an episode are not accurately and fully captured. Inconsistent enrollment with a payer during the episode. Consistent enrollment ensures that all costs associated with the episode are accurately and fully captured. Patient exclusions. Patients who also have a UPPP on the date of the procedure have a different clinical pathology than relevant tonsillectomy or adenoid tonsillectomies. As a result, the severity of care and the episode cost is extremely different and variable as compared to relevant episodes. Patients with a BMI greater than 50 are also excluded. They are at higher risk and are more complicated to operate on. The PAP cannot control this risk or the variability in outcomes due to this patient condition. Patients with a death in the hospital are clinical outliers and would be excluded from the episode. Patients who left against medical advice are excluded because the PAP cannot be held responsible for outcomes and resulting cost of care if the patient leaves AMA. On this slide, you will see reflected the patient exclusions, the care setting exclusions, and the severe chronic diseases and procedures that will cause an episode to be excluded. More patient exclusions are found on this next slide. They range in severity from cancers to pneumonia, fetal disturbances, spontaneous abortion, suicide, and intentional self-inflicted injury. These diagnosis codes are the ones that are used to help determine the exclusions of the patients from the episode. Quality metrics. The rate of admission of intraoperative steroids is a quality metric that is tied to gain sharing payment. To qualify for gain share, providers or their staff must report these quality metrics through an online provider portal. Providers must meet the minimum quality standards agreed upon by a clinical advisory board. Quality and utilization metrics for reporting only include a bleed within 24 hours post-surgery, known as a primary bleed. That is usually related to surgeon technical skill and can drive post-procedure admissions as well as unplanned returns to the operating room. A bleed within 2 to 14 days post-procedure is less related to physician efficiency, but should still be monitored. The Academy of Otolaryngology has recommended against post-procedure antibiotic prescriptions in its revised tonsillectomy guidelines from 2011, and so one of the quality metrics we'll be monitoring is the rate of antibiotic prescription post-surgery. The principal accountable provider. Each payer determines their own definition of the PAP by looking at decision-making responsibilities, influence over other providers, portion of episode cost. Medicaid has publicly announced that the PAP will be the primary provider performing the tonsillectomy, adenoidectomy, since they are in the position to influence the most decisions and costs.